Well, welcome on behalf of the International Health Committee of the ATS. We are glad to have you here at this webinar entitled Global Priorities in the Fight Against Pneumonia on November 12th, which coincides with World Pneumonia Day. As a note, World Pneumonia Day is observed on November 12th every year to raise awareness about the life-threatening but preventable respiratory illness. And today we have a fantastic set of speakers who are experts in issues around pneumonia in the world. We first have Leith Greenslade, who is the coordinator of the Every Breath Counts Coalition, an alliance of more than 100 organizations working together to help low and middle income countries reduce deaths from pneumonia. We also have Eric McCollum, who is a pediatric pulmonologist at the Johns Hopkins University School of Medicine, who has expertise in global child respiratory health with more than 18 years of clinical and research experience in many parts of the world. Also, Mohammed Chisti, who is a pediatric infectious diseases physician and with expertise in pediatric critical care medicine. And finally, you also have Rebecca Natanda, who is a general pediatrician and senior research scientist at Makerere University Lung Institute. And her research focuses on lung health in children, particularly pneumonia and asthma. So we are incredibly excited to have this panel of speakers with us today. And we will go ahead and start with the webinar that is being kicked off by Leith Greenslade.
So thank you very much to the American Thoracic Society for the opportunity to speak with you on World Pneumonia Day. My name is Leith Greenslade, and I'm coordinator of the Every Breath Counts Coalition. And I will be speaking with you about global priorities in the fight against childhood pneumonia. And I want to start with a bold claim, and then I have 10 minutes to persuade you to support that claim. So it's now possible to reduce childhood pneumonia deaths to the global target by 2030 if we prioritize high coverage of 5 interventions across 20 countries and mitigate the risks of another respiratory pandemic and antibiotic-resistant pneumonia pathogens. So why are we saying that at Every Breath Counts? First of all, just look at how close we are to achieving the global child pneumonia target. These are pneumonia deaths, child pneumonia deaths, children under 5 from 2000 to 2020, where we are now, and then projected out to 25 and 2030. So there's 2 sources of data we look at to track child pneumonia mortality. The global burden of disease, which is the blue line, then the UN estimates. They're different. They broadly track each other, but they're different, a little different, particularly during the COVID years. So even looking at both of those sources of data, we're still very, very close. So in 2025, we have a target for pneumonia. The target is around 397,000 deaths. Projected out to 2030, it comes down to about 266,000. Currently, according to the GBD, we're at around 500,000 child pneumonia deaths. So we are so close to achieving these targets, but we will only get there if we have a very targeted strategy now in the countdown to 2030. So both, we always have to look at neonatal and post-neonatal deaths when we're talking about children with pneumonia, because it's a big cause of neonatal deaths as well. But the good news is they're both tracking down. The blue line is post-neonatal, which is children 1 to 59 months, 62% decline since 2000, and nice reductions as well in the neonatal, 58%. So that's all good news. What are the pathogens that are driving these deaths? In the neonatal period, there are just 10 pathogens driving 70% of deaths. You can see what they are there. And look at the dominance of bacterial infections still. Look at the burden of Klebsiella, pneumoniae as well, huge. GBS as well, RSV, viral as well. And there are 9 risks. We always have to look at the pathogen causes as well as the risk factors. Both are important. And look at the huge influence of low birth weight and short gestation on neonatal pneumonia deaths. Also household air pollution, hand washing, but look at low birth weight. When we move to the post-neonatal period, 10 pathogens are responsible for 80% of the deaths and look at strep pneumoniae. These are different, right? Important. It's different for neonates and post-neonates. Once again, dominance of bacteria, but you'll also see viral. Look at RSV and influenza in there as well. When we look at the risks for post-neonatal pneumonia death, look at malnutrition. Overwhelmingly malnutrition in all its forms, underweight, wasting, and stunting. But household air pollution also important here. We need to keep those in mind. We always have to stop after we look at our mortality data and ask the question, what does CHAMPS say? CHAMPS, if you don't know, is a wonderful new database of what's causing child deaths. It's looking at mortality after the children die. They do autopsies, minimally invasive tissue sampling, to determine the cause of death. So it's very precise, and they share that data. The data comes from the countries that are highlighted there below: Ethiopia, Kenya, Mali, Mozambique, Sierra Leone, South Africa, and Bangladesh. And what does it say about pneumonia? You can see it basically agrees with what we've just presented you in terms of what global burden of disease and UN data is saying. So pneumonia is a cause of death in 41% of CHAMPS children, which is huge. You've got a number of other statistics there that are fairly important. I just want to pull out a couple. 67% of deaths are in the community, meaning they occur at home or within 72 hours of hospital admission. That's a huge proportion of deaths really are outside the health system or in the early hours of admission. Bacterial causes, we've already heard about that, huge influence. And then the pathogens, once again, they're calling out Klebsiella pneumoniae and a few others. Viruses are also very important. You can see RSV listed there as well. So broadly, our CHAMPS data is in accord with what our other data sources are telling us. Do we have the tools to fight the leading causes of childhood pneumonia? This is a happy slide, hence the pretty colors. We do. We have a lot of tools. On the prevention side, of course, always better to prevent. We have vaccines. They're listed there. But what's exciting is we have new vaccines coming: the RSV maternal vaccine, the monoclonal antibodies that the infants get just after birth. We have pipeline vaccines for Klebsiella pneumoniae and GBS. So the vaccine space for pneumonia is very, very exciting. We, of course, have a raft of other tools that get at the risk factors: hand washing, safe water, etc. But if a child gets sick, let's move to the right-hand side of that white dividing line. We have a whole lot of diagnostic tools and treatments. That's why we call these deaths preventable, because we do have these tools. Now let's move to the unhappy slide. Do the most vulnerable children get them? This slide is orange and red because this coverage data is woeful. If we look at the vaccines, these wonderful vaccines we have for pneumonia are at relatively low coverage. Look at PCV. 65% of children get the pneumococcal conjugate vaccine globally. Influenza, we don't know, we don't collect it. RSV is at 0, but we want to drive that up. Klebsiella pneumoniae is in the pipeline. So is GBS. So the vaccine picture here is not as positive as it should be. The coverage of hand washing, drinking water, sanitation, a little better, but still not great. Then when we move to the right-hand side of the line to the children when they become sick, look at care seeking for pneumonia. Just 60% of children are taken for care to an appropriate provider, leaving 41% at home with nothing or taken to various forms of traditional medicine. When we move to diagnosis, we don't know. We don't measure pulse oximetry coverage. We don't have great tools for clinicians and health workers to diagnose pneumonia. When it comes to treatment, we don't have an effective indicator to measure antibiotic coverage. We don't know what medical oxygen coverage is. We know about wasting treatment, but it's woeful, 25%. So this is a very unhappy slide that needs urgent attention. We need to increase coverage of all these fantastic tools. Another important point we like to underscore is we don't need to increase coverage everywhere, because pneumonia deaths are very, very concentrated now, childhood pneumonia deaths, just 80% in just 20 countries. 14 of these countries are in Africa, 6 in Asia, and they're color-coded here. These are numbers of deaths annually. So the red countries have the largest numbers of children dying, orange second, and then our yellows. So this screams out at us that we need a very targeted strategy to reduce child pneumonia deaths and increase achievement to the SDGs. But 2 other things on the horizon that we always need to keep in mind when we're talking about priorities: antibiotic resistance. There's been some terrific data out, cited here. The Lancet's starting to publish some great data on antimicrobial resistance. The pneumonia pathogens are a real problem. So we need to stay very, very focused on the vaccine agenda, because increasing vaccine coverage will reduce demand for antibiotics and reduce resistance. We also need some new antibiotics, definitely, in this space, more effective antibiotics. But our vaccine agenda should really get at this problem of antimicrobial resistance. What about pandemic risk? We've just had a massive respiratory pandemic with COVID, which caused mass fatalities. Fortunately, it did not disproportionately affect children. Adults were disproportionately affected, but that may not be the case next time. So here are some of the latest estimates just published on the risk of another respiratory pandemic. It's very high. Next time it could affect children, which means we would have a pandemic of pneumonia among children potentially. So we need to stay very focused on mitigating a respiratory pandemic risk with a strong focus on children. This data suggests that the greatest risk comes from influenza and another coronavirus type pandemic. So we need to really keep our eyes on this. So from all the data that I've just showed you, what kind of priorities fall out? I want to present 5 to you. Number 1, we must achieve 90% coverage of our existing pneumonia vaccines. They need to be made more affordable. They're still too expensive. Hib, PCV for sure, that's a no-brainer. We need to get those new RSV tools out and at full coverage by 2030. Number 2, we also need to accelerate development of the new pneumonia vaccines, the Klebsiella pneumoniae and the GBS that are coming. We need to accelerate that and get them out, particularly into the countries you see listed on the right. That's just an infographic of the top 20 countries where child pneumonia deaths are concentrated. Number 3, we have to integrate malnutrition, prevention, diagnosis, and treatment with vaccination. This is our best chance at getting these wonderful new nutrition interventions at full coverage. We have some new prevention, wasting prevention, nutritional supplements coming, the SQLNS. The newborn probiotics field is really accelerating, so we can start to help the children under 6 months of age, which have they've had no real nutritional support available to them, apart from human milk banks. And of course, all the RUSFs and RUTFs, the ready-to-use therapeutic foods, and the new maternal micronutrient supplements. This is an exciting package of nutrition inventions, but we won't get them at full coverage unless we have a distribution mechanism. And our suggestion at Every Breath Counts is just integrate that with vaccination, maternal, newborn, and child vaccination. Don't forget that malnutrition drives 50% of pneumonia deaths. So the more we can increase nutritional status of children, the more successful we are at preventing deaths from pneumonia. Number 4, the diagnostic space in pneumonia is still lousy. We have to have increased access to the tools we have, pulse oximetry, but we must get a better generation of pneumonia diagnostics. I've listed some here that are particularly exciting. And our oxygen antibiotics, we have to get at full coverage and measure it, because we're really in the dark at the moment. We don't know the coverage statistics for children. And finally, number 5, mitigation of respiratory pandemic and AMR risks. We need our childhood pneumonia community to get much more focused on these 2 areas. If we do these 5 things, we stake a flag that we can achieve by 2030 the childhood pneumonia targets. This will not only help childhood pneumonia deaths, but will help the child survival SDG 3.2 goal, because pneumonia is still the leading infectious cause of childhood death globally and in many countries. So the more we can reduce our pneumonia deaths, the more we help the world achieve SDG 3.2. So I hope I've persuaded you about these 5 priorities, and it's been a pleasure to speak with you today. And thank you again to ATS. Thank you.
Lee, thank you very much for that. Now moving on to Eric McCollum, who's going to be addressing pulse oximetry.
All right, I'm going to turn off my video, but really a pleasure to be here today. Thanks to ATS for the invitation. My name is Eric McCollum, and the title of my presentation that I've been asked to talk about is Can Pulse Oximetry Reduce Pediatric Pneumonia Deaths When Used in Outpatient Settings? It's a lot of ground to cover, but before I delve into that main question, I did want to talk first about whether blood oxygen levels in children with pneumonia is an important issue. It kind of sets the table for the question that we're trying to address in the talk. And the answer is biologically yes. Oxygen saturation, which is the proportion of hemoglobin bound with oxygen, is really what matters most when we remind ourselves of oxygen when it's circulating in the bloodstream. The vast majority of that oxygen is bound to hemoglobin, as you can see below. And epidemiologically, we would also say yes. So when blood oxygen levels are low, we call that hypoxemia, and it's very common. In a really wonderful meta-analysis published by Rahman and colleagues a couple years ago in 2022, it showed that the hypoxemia prevalence is 31% in a data set of more than 100,000 children with pneumonia from low and middle income countries. The authors estimated that in 2019, about 7 million children were hospitalized with hypoxemic pneumonia. And when that data was restricted to the outpatient space, the data is not as robust, but it still suggested that the prevalence of hypoxemia remains high. From a mortality risk, it is indeed important. Hypoxemia has a strong association with death, and in this meta-analysis, courtesy of Nadia Hoekstra, Kristen Joseph, and Holly Schuh, unpublished data, this shows in a meta-analysis of nearly 50,000 children from 32 studies that hypoxemia, no matter how that's defined, and we'll come back to that, has a high odds ratio for death of 5.3. And lastly, there's treatment, and it's available, oxygen treatment, and it's effective. In a meta-analysis by Felix Lam and colleagues from a few years ago, they showed in an area it is candidly difficult to study oxygen as an intervention. But in the 4 effectiveness trials that were included in this meta-analysis, they showed that oxygen treatment, when an enhanced system was implemented compared to kind of a baseline oxygen system, that the odds ratio for mortality fell by 50%. And then in addition, the cost effectiveness of oxygen system implementation is in line with other pneumonia interventions such as vaccines, breastfeeding, and cleaner cook stove interventions. So I think the answer to this initial question, setting the table for the main question of the talk, is a yes for these reasons. And so back to the question of the talk is of whether outpatient pulse oximetry can reduce pneumonia deaths. The answer in my mind is yes. I don't see any reason that children with hypoxemia and pneumonia presenting to care in the outpatient space would be any biologically different than children presenting to care in the hospital space. But what's really important is whether the implementation and the impact of pulse oximetry in the outpatient space can reach its potential does depend on some key factors, and I'm going to talk about those factors in the remaining of the talk. One, as Leith alluded to, is care seeking. This is a highly complex issue. And a humbling issue to frankly contemplate. But when caregivers do recognize that their children may have pneumonia or are sick, there's a couple patterns of care seeking that emerge. One is that they will go back and forth, looking at the dotted lines there, to informal or even formal community-based even primary healthcare clinic care, and they may go back and forth several times, but those levels of the health system are not well equipped at the moment to identify hypoxemia. And that then results in some kids of progression of their illness, developing into severe disease, and then ultimately caregivers will take their children to the hospital, which is where there's a higher likelihood of oxygen, pulse oximetry, injectable antibiotics available. And caregivers do know that. And then the second scenario is that caregivers, for a myriad of reasons, are unable to take their child even though they recognize the child's sick. And so they, again, present to care late, but they'll take their child directly to the hospital. Caregivers, understand the health system in their local context. They generally know that the outpatient or community-based clinical care is really tailored more for milder illnesses, for preventative care, whereas the sicker care is really residing in hospitals. And so there is forthcoming data coming in 2025, likely, that is evaluating the impact of pulse oximetry in outpatient care, and it's probably going to be underwhelming. And I would argue that in part, why that data is likely to look underwhelming is for this care-seeking reason. It's really complex to change behavior. And in studies, frankly, that are done in the outpatient space are just not done long enough, likely, to really influence this care-seeking behavior and kind of the underlying structural issues in the health system. But ultimately, we want kids to be accessing care earlier in their illness, and that would be at the community level in the outpatient setting where pulse oximeters are not readily available. The success of outpatient pulse oximetry also depends on pulse oximeters, perhaps an obvious statement. Pulse oximeters, just as a reminder, are medical devices that non-invasively measure the peripheral arterial oxyhemoglobin saturation, which we short as SpO2, which are devices that generally function on this principle that oxygenated, so hemoglobin that's bound with oxygenated and oxygen, and deoxygenated hemoglobin that's lacking oxygen, absorb red and infrared light differently. And the biomedical engineer pictured in the top left of your screen, Takeo Ayaji from Japan, somewhat stumbled upon this principle of infrared and red wavelength light more than 50 years ago, and is considered the father of pulse oximetry. And so this is not really new technology. The other notable thing with pulse oximetry is that the pulse oximeter SpO2 accuracy for the gold standard arterial oxygen saturation that's typically obtained in an arterial blood gas is calibrated within plus minus 2%. And those calibration tests are done in adults, and we'll come back to that point. So, one of the silver linings of the COVID pandemic, there are a few, is that there was a lot of increase in pulse oximeter access in LMICs, as well as momentum on oxygen implementation. But the unfortunate part is that not all pulse oximeters are the same. They differ in accuracy, and a lot of the pulse oximeters, unfortunately, that were distributed during the pandemic were not necessarily FDA cleared. And so this study that's done by Mike Lipnick and colleagues at UCSF was done in a controlled hypoxia laboratory in the US on 22 adults. And what they did is they evaluated 6 devices that were not yet cleared by the US FDA, but were available in LMICs. And really the bottom line here is that, disappointingly, they only found that 2 of them met the US FDA pulse oximetry requirements, which those are the current requirements, and I should note that those may change. But in this graph, broadly speaking, this on the y-axis, it's examining bias, which is the difference between SpO2 and SaO2, so the pulse oximeter and the arterial blood gas oxygen saturation. And then the x-axis is the gold standard SaO2. And basically what I've boxed in red there is that plus minus 2% accuracy threshold. And the goal would be you'd want all of those dots representing the different measurements from the different devices to be falling within that box. And you can see here that the authors demonstrated that a lot of those measurements, the spread is quite wide and outside of that target range. And I just do want to plug the Open Oximetry group. The link is there on the right-hand side of your screen, led by Mike Lipnick and colleagues. They are developing an ongoing, transparent repository of pulse oximetry accuracy. And so you can keep track of how devices are performing on their website. So please do check that out. The other important aspect of pulse oximeters, maybe the dirty secret on some level is that they are, developed, designed, and tested on adults and then assumed to work on children. And unfortunately, children are not little adults. They have unique needs specific to pulse oximetry that affect the measurement. And that includes, they understandably come in all different shapes and sizes. They have different different areas of measurement, surface areas of measurement. They move more than adults during measurements. They, particularly if they're younger, have more labile perfusion, faster heart rates. All of these factors can influence the performance of pulse oximetry on children. And so we really are lacking, particularly in LMICs, quality devices that are affordable and that are co-designed for the needs of children and the usability needs of healthcare workers in low and middle income countries. And then they're tested on children. They're improved, they're iterated. And our project called PFUMLA, we're trying to tackle this. And we have developed, as pictured here, a mobile phone-based reflectance pulse oximeter designed for children, co-designed with healthcare workers in South Africa, and currently undergoing rigorous testing. And we hope to be sharing a lot of that data at the ATS meeting in May. Another really important factor for the success of outpatient pulse oximetry is choosing the right SpO2 threshold. And this gets back to that hypoxemia definition idea. So currently, the World Health Organization recommends an oxygen saturation of less than 90% as the threshold for either referring or initiating a child on oxygen. And what you can see here from this graph, it's really lovely graph from Hamish Graham that he published with our group earlier in the year. And what Hamish showed here was that very eloquently that the mortality, the odds of mortality, the odds ratio for mortality is depicted in the y-axis against the SpO2 measurement in the x-axis. When you look above that less than 90% threshold, you can see that the odds of mortality doesn't vanish. Understandably, it really functions more as a dose-dependent relationship. And so you can see that mortality risk is still high and it persists and does lower though as you move upward on the SpO2 scale. And that the cut point kind of looks more like a less than 94%, perhaps less than 93% threshold. And so Nadia Hoekstra again and colleagues, unpublished meta-analysis, looked at this more as a categorical variable in their meta-analysis. And then in the data in which we could do this meta-analysis, we restricted the SpO2 range to 90 to 94% and showed here that this threshold still had an elevated odds ratio for mortality of 2.8 in 4 studies across 15,000 children. And so how do LMICs kind of make that decision? Do they stick with that less than 90% threshold, or do they perhaps consider moving to a higher threshold? The caveat being that when you do move to a higher threshold, you are going to be referring more children. Although they are at a higher risk of mortality, you are referring more of those children to the hospital. And so it is a balance between the considering the kind of limitations, I guess, of the health system versus the needs of the hypoxemic child. Some of the factors to consider on the health system side would be oxygen capacity, bed capacity, human resources. Altitude is perhaps another important consideration when considering threshold. And then from the patient perspective, age, comorbidities like malnutrition, like Leith alluded to, HIV, anemia, and so forth. And so, I think at the end of the day, the decision to consider a higher threshold is going to have to be made on a local basis, probably. The success of outpatient pulse oximeters also, of course, depends on oxygen access. It's really important to link pulse oximetry with timely oxygen, and this can be done in either of two ways: with robust referral systems, such as ambulance access, noting that this is really difficult to achieve in a lot of LMICs, particularly when we move out into the more rural areas. And so probably moving some flavor of oxygen systems downstream in the health system is going to be a more near-term solution. But again, I just want to point out, Hamish Graham and colleagues again had a wonderful study from Nigeria, a cluster randomized trial, where they rather unexpectedly and surprisingly found that when they introduced pulse oximetry before even introducing the trial's oxygen intervention, they found that they lowered mortality by 67%, the odds of death by 67% for children with lower respiratory infections like pneumonia. And that data was interpreted understandably that this was related to the fact that, while we can use pulse oximeters to accurately identify the right children, the hypoxemic children, and give them oxygen. So timely oxygen, super important. And then lastly, I will not dwell on this, but just make a note on leadership. It's going to be really important, and that falls on all of us. The World Health Organization IMCI guidelines are excellent guidelines that they form the framework and basis of child pneumonia care for the past 25 or so years. The challenge right now is that these guidelines miss 2/3 to 3/4 of hypoxemic children. And you can see here that, and this would be addressed if pulse oximeters were available. And this has been shown in multiple studies across several regions. And you can see I boxed in red here, the current guidelines really don't firmly recommend pulse oximetry. They don't mandate it. The statement is to use if available, and if the oxygen saturation is below 90%, then to refer. And I think it comes down to a bit of philosophy on what are policies and what are guidelines. They do need to remain pragmatic for LMICs, but perhaps they could be more visionary and kind of show the road to where we want to go, and that may motivate the community and private sector and NGOs and so on to further invest, develop, and innovate in this outpatient pulse oximetry space. So that was a lot of ground to cover. I talked really fast. Sorry about that. But basically, hopefully I've convinced you that we can get there, if we can really pay attention to care-seeking devices, the right oxygen saturation threshold, oxygen linkages, particularly timely oxygen linkages, and strong leadership. I do want to make a quick plug for the Union Child Pneumonia Working Group. We have our annual meeting tomorrow, Wednesday, November 13th, here in Indonesia, where we are. Unfortunately, it's a bit early on the US side. There's a registration link there below, and my email is listed there below. Thanks so much for your attention.
Eric, thank you so much for the talk. And the next recording is from Mohammed Chisti. He is not available, but we do have his recording.
So, my dear respected audience, greetings from Bangladesh. The title of my presentation is Role of Bubble Continuous Positive Airway Pressure on Treatment of Severe Pediatric Pneumonia. As you are aware that pneumonia is the #1 infectious killers disease globally. It usually accounts for 138 million new cases in each year. Among them, 11.9 million required hospitalization. And among them, 0.7 million cases used to die in each year, which is actually 14% of the 5 million under 5 deaths. And if you see what are the main culprit of pneumonia-related deaths, in a systematic review, it has been found that children who has pneumonia and hypoxemia have the 5 times higher more risk of death compared to those who didn't have hypoxemia. That does mean that if we can manage hypoxemia efficiently, then we can reduce the pneumonia-related deaths. So if we see the prevalence of hypoxemia, you can find that globally there are 31% hypoxemia among the hospitalized cases with pneumonia. And in Bangladesh, the prevalence is much more higher. It is around 40%. That does mean that it emphasizes that the management of pneumonia is critically important to reduce pneumonia-related deaths. So how this hypoxemia used to be managed, especially pneumonia-related hypoxemia globally, especially in low and middle-income countries? There is WHO recommendation. With this recommendation, with appropriate antibiotic, with WHO recommended low-flow oxygen and other supportive care, you can see there are mortality is in many hospitals which exceeds more than 10%. That does mean that if we need better oxygen support and we can afford this, we might reduce these deaths further. So on the search of that, continuous positive airway pressure might be one of the options, as it can exert continuous pressure and might reduce pneumonia-related deaths further by easing respiratory support as early as possible. And it is used to derived in 3 sources conventionally. And number 1 is the mechanical ventilator, but the mechanical ventilator, you know, it is expensive, and not only expensive, it needs special training for the nurses and doctors. And even though nurses and doctors are well trained in developing country facilities, it is associated with hospital-acquired infection and high mortality. Then we thought that there is how we can go with a non-invasive ventilation, like bubble CPAP or high-flow cannula oxygen therapy. So bubble CPAP it can be provided by low cost and also by conventional commercial bubble CPAP. But in both the cases, it used to work by reducing the functional residual capacity, which it used to reduce, and it tries to retain that functional residual volume and ease the respiration. It actually exerts continuous positive airway pressure and creates positive and expiratory pressure to retain that. And high-flow nasal cannula is very popular in Western countries, especially in case of bronchiolitis, which is used to reduce the indication of mechanical ventilation, but it exerts uncertain CPAP or PEEP. So we try to understand what is the knowledge gap by doing a systematic review, and we have found that the systematic review that we have done to evaluate the efficacy of bubble CPAP in case of children with severe pneumonia and hypoxemia compared to high-flow nasal cannula oxygen therapy, as well as WHO standard low-flow oxygen therapy, we found there is no trial that evaluated the efficacy of bubble CPAP or hypronasal cannula compared to WHO standard low flow oxygen therapy in treating children with severe pneumonia and hypoxemia, especially beyond the neonatal period. This is why we designed a randomized trial in Bangladesh, where we used this locally made bubble CPAP, which actually needs only a WHO recommended nasal prong with a water-filled plastic bottle. And by this device, the patient can receive oxygen from an oxygen source, especially from the oxygen cylinder. And after taking oxygen, patient exhales air. That exhaled air passes through the water-filled plastic bottle by producing bubble, and that bubble gives the back pressure, that is positive and expiratory pressure, which used to helps to recruit the lung volume, which used to be lost due to pneumonia. And by this way, it increases the residual volume, which used to be lost during hypoxemia related to pneumonia. And by this way, it works. And in that randomized trial, we have found that bubble CPAP, especially patients who received bubble CPAP, had a significantly lower treatment failure as well as lower deaths compared to those who did receive standard low flow oxygen therapy. However, if you see the comparison between bubble CPAP and hypronasal cannula, especially mortality difference, there was clear-cut trend, but it didn't gain the adequate statistical difference. However, after publication of this trial in Lancet, the pediatric intensivist as well as statistician from France further analyzed our data using Bayesian model, and they found that bubble CPAP intervention not only better than standard low flow oxygen therapy, but it also works better, especially mortality benefit was there compared to hypronasal cannula oxygen therapy. So after our trial, there was another trial which was done in Ghana by Professor Patrick Walson and his group among the children with undifferentiated respiratory distress, where it is showed that there is no mortality difference among the under 5 children. However, in post-hoc analysis, it has been shown that bubble CPAP had significant mortality benefit among the infants compared to WHO standard low flow oxygen therapy. And a subsequent trial done in Malawi in children with severe pneumonia and with the different danger signs, it has been found that bubble CPAP didn't work, and the main focus of that trial was to whether bubble CPAP did work in case of supervision done by nurses without a daily supervision of the physicians. So after initial to successful and followed by a successful trial, we were in a skeptical position whether a bubble CPAP really worked in case of children in severe pneumonia and hypoxemia. Then by this time, we actually implemented bubble CPAP as the part of the standard of care in Dhaka Hospital of ICDDRB. And after 5 years of implementation, it has been shown that bubble CPAP was not only associated with the reduction of mortality, it was also associated with the reduction of the indication of mechanical ventilation, and by which it also reduces the total oxygen consumption cost. significantly compared to the pretrial period. And it is important to mention that it is a very large data set, it's around 10,107 children, among them 2,500 children in the pretrial period, and around 300 children, around 3,000 children during the trial period, and around 4,600 children in the post-trial period. However, we wanted to take a bubble CPAP from the tertiary hospital to secondary hospitals where there is good monitoring from the learning of our Malawi trial. And we have found that the feasibility and acceptability in Bangladesh and Ethiopia, which were done simultaneously, it was shown that bubble CPAP with the supervision of nurses, that is the monitoring of the nurses with the supervision of physicians, especially daily clinical round of the physicians, it was very effective. It is important to mention that it was found that bubble CPAP was acceptable to not only to clinicians but also to caregivers. And it is found that bubble CPAP worked nicely, especially in under the monitoring of nurses with the supervision of doctors, especially by the daily round of the doctors, and there was consultation of the pediatrician when it is possible. And we have also find that in those hospitals, there were dedicated corner for bubble CPAP patient, especially in front of the nursing station, which minimize the time to nursing the baby if there is any issues raised. And from that learning, we addressed all the challenges which were found during the feasibility study. And after addressing that, we have designed a cluster randomized trial in Ethiopia in 12 district hospitals. And we have done this study where 6 hospitals received standard low flow oxygen therapy, and other 6 hospitals received a bubble CPAP oxygen therapy. And there, and according to our learning from previous studies as well as from our feasibility study, we had a dedicated corner in front of the nursing station for all the 12 hospitals, and there were monitoring by the nurses initially 4 hourly for the first 24 hours, then 8 hourly for the rest of the period. And there was daily clinical round by the doctors, and whenever possible, consultation with the pediatricians. And it is found that in each arm there was 620 children, and it has been found that children who received bubble CPAP had the significant reduction of treatment failure compared to the children who received low flow oxygen therapy. And we adjusted potential confounders, and after adjusting each of the confounders which were shown in actually baseline analysis, still bubble CPAP shown that it is associated with the lower treatment failure. And it is not only associated with the lower treatment failure, it is also associated with the significantly lower in hospital mortality, as well as children who received bubble CPAP had the lower length of hospital stay and the lower duration of intervention compared to the low flow oxygen therapy. That does mean that bubble CPAP, if we have a, adequate, quality, and the setup is in adequate format, and it can be implemented very easily. So from these findings, we can recommend that from the series of studies and observation, we can tell that the growing evidence on the clinical benefit of bubble CPAP oxygen therapy from low-income and middle-income countries in Asia and sub-Saharan Africa suggests that bubble CPAP should be available for the care of severe childhood pneumonia and hypoxemia in setting able to provide sufficient monitoring, staffing, and pediatric supervision. And implementation research with cost-effectiveness analysis may be required to scale up bubble CPAP in Southeast Asia and sub-Saharan Africa. And you will be pleased to know that from this series of studies, especially our last study from Ethiopia, policy makers both in Asia and sub-Saharan Africa agreed to have implementation research followed by scale up of bubble CPAP, and it has already been started in Africa, especially starting with Ethiopia, 24 hospitals and 12 hospitals in Nigeria and 1 hospital in Malawi, and it will be scaled up for the next 5 years, where they will also get the answer which patient will be the best benefited from this low-cost locally made bubble CPAP. And we are looking for that, and hopefully it will be associated with significant reduction of mortality from pneumonia, which can help to attain sustainable development goal by 2030, especially sustainable development goal 3.0. So thank you for all of you for your patience hearing. So I'll be available for the question and answer session if requires. I also want to acknowledge all the investigators as well as bubble CPAP group in Bangladesh, Ethiopia, and Nigeria and Malawi, and also our pneumonia working group led by Carrick McCullum, as well as Leith Greenslade. And thanks to all of you for your patience hearing.
All right. Well, next on to Rebecca Natanda.
Good morning, good afternoon, good evening, wherever you are. My name is Rebecca Natanda. I am a pediatrician and a research scientist. I work with Makerere University Lung Institute in Uganda. I also co-chair the Child Pneumonia Working Group of an organization called the International Union Against Tuberculosis and Lung Diseases, commonly known as the Union. I want to thank the organizers of this webinar for giving me an opportunity to contribute to the discussions around gaps in childhood pneumonia research priorities. I want to start by highlighting what probably most of us know, that deaths in children less than 5 years are more common in countries in Asia and sub-Saharan Africa. Indeed, statistics shows that 4 out of the deaths in this age category are from these countries, and I want to emphasize that majority of these deaths are actually due to childhood pneumonia. This pattern is exactly what we see when we are analyzing child pneumonia deaths, with majority of the deaths really occurring in high burden income countries that are found in both low and middle income countries, particularly those in sub-Saharan Africa and Asia. What are the implications? It means that if we are to reduce the global pneumonia deaths, we must focus the available resources to addressing research priorities that have been identified as key in the context of the low and middle income countries. The good news is that research on pneumonia interventions around protect, prevent, and treat have been observed to contribute greatly to preventing pneumonia deaths. Specifically, we need to urgently conduct research on the major barriers to reduction of pneumonia deaths, again focusing on the high burden regions. Childhood pneumonia research priorities have been previously identified. For example, in 2008, Scott and colleagues published a study in which they identified etiology to guide vaccine and antimicrobial therapy, pathogenesis to improve case management, surveillance tools and new diagnostics, as well as evaluation of the impact of prevention and case management strategies on mortality and equity as key research priorities at that time. 3 years later, Rudan and colleagues published a study in which they identified healthcare seeking behavior, access to vaccines, vaccine coverage and efficacy, health system capacity to diagnose and treat pneumonia, as well as the role of community workers as key research priorities that needed to be addressed to contribute towards the reduction in pneumonia deaths. What we observe in both these studies is that the issue of diagnosis and therefore treatment came out clearly as a key research priority, and as we shall see later, it still remains an important research priority, meaning that it hasn't yet been addressed and contributing to the deaths in children less than 5 years. Between 2019 and 2021, King and colleagues conducted an e-Delphi study. This study comprised of experts from both high-income countries as well as those from low and middle-income countries. And this included clinicians, people from pneumonia programs, funding agencies, non-government organizations, the academia, as well as other people. The good thing with this analysis is that they went further to analyze the research priorities globally, but also focused on those research priorities that were identified by the experts from low and middle income countries, because this is where the greatest burden of disease is. They went ahead to rank the priorities, again based on what the experts from low and middle income countries provided, but also looking at a ranking from a global perspective. They categorized these priorities into 4: prevent and protect, diagnosis, treatment, as well as those priorities that were cross-cutting. I want to share some of the things that stand out from this analysis regarding research priorities. Number 1, issues around identification of children with hypoxemia and urgent management, including pulse oximetry and oxygen therapy, were noted to be cross-cutting across the 4 categories. And this really highlights the importance of urgently conducting research to address hypoxemia and oxygen systems if we are to reduce the pneumonia deaths, particularly in low and middle income countries. The study also highlighted both health system capacity strengthening, including community health systems, as well as low-cost point-of-care diagnostics as research priorities, again cutting across the 4 categories. And this highlights the fact that to date, we have not yet been able to address, because these were already identified by Rudan and colleagues in 2011. So the gaps have persisted several years down the road, and this is contributing partly to the slow reduction in the pneumonia deaths that we observe. Another important findings was the fact that 3 of the top 5 priorities that were identified by experts from low and middle income countries were not even among the top 20 priorities that were identified overall. And this makes us see the fact that the priorities as seen from the global perspective are quite different from the priorities as seen by the experts working in low and middle income countries. And probably this speaks to the funding that is directed towards the priorities as seen from the global perspective and priorities as seen from the perspective of the low and middle income countries. Using the information from this Delphi study, Steele and colleagues conducted a desk review to analyze the investment that is directed towards pneumonia research. And they also developed a scorecard. I'll not be able to go into the details, but the findings from this analysis showed major funding gaps. For example, between 2000 and 2015, less than 3% of the funding for infectious diseases research was directed to pneumonia research, and this is compared to 38% for HIV. This is not to say that HIV is not important, but we must find a way of also directing resources to the #1 killer of our children less than 5 years. Another important finding that even the little funding that was available, most of it was focused on vaccines. Again, I'm not saying that vaccines are not important. They have really helped a lot in reducing pneumonia deaths. But it was noted that less of the funding was spent on other priorities like diagnostics and treatment, as well as health system capacity strengthening. Yet these are important key research priorities that have been identified through the different studies. Another key finding was the fact that only 8% of the funding for pneumonia-related research was spent in low and middle-income countries, despite these countries having 99% of the disease burden and pneumonia mortality. In conclusion, we note that the current funding is extremely insufficient to address the pneumonia research priorities, and I'm calling upon the funders to also focus on research priorities that have been identified by colleagues from low and middle income countries, because these bear the greatest burden of pneumonia deaths. We need to conduct implementation science research to urgently optimize the implementation of the available interventions, because they've been known to work, but we need to find a way on how to optimize them to contribute towards reduction of the pneumonia deaths. And lastly, there is urgent need to increase investment in areas of pneumonia research that really have the greatest potential to accelerate the reduction in pneumonia deaths, both globally, but particularly in low and middle income countries, if we are to achieve the Sustainable Development Goals. I want to thank everyone for listening to me, and I'm happy to take some questions and comments. Thank you.
All right. Well, thank you so much. I think there's an opportunity to answer some questions from the attendees. I don't know if there are any questions from the attendees for any of the speakers. Well, Eric, I could start off with one question. I think you mentioned the importance of altitude and thresholds. And knowing that there is a large proportion of the population that lives above 1,500 meters, how to best adapt thresholds with varying altitudes to be able to determine that risk of death and pneumonia?
Thanks. It's an excellent question, and in the back of my head, I knew you were going to ask me that question. I think that I don't think that we have enough data yet, to be honest, in higher altitude settings, other than to kind of know that the threshold is likely to be different. I think one of the approaches that we took in a low altitude setting in Bangladesh to try and understand a bit more about where that cut point might be better, linked in terms of that threshold of risk. We went through the effort of measuring oxygen saturation on healthy children that in Bangladesh. So that's obviously at low altitude, sea level. And through that, we were to kind of better understand the distribution of the oxygen saturation levels in these healthy kids. And then we applied that to a sicker population using the fifth percentile of the healthy kids as that lower limit of normal. And through that work, which we have published a couple years ago, we were able to show that that approach did help us identify kind of this risk, this group of kids who still have an independent risk of mortality, but are above that less than 90% threshold. And so what I would say, Will, is that a similar approach could be undertaken in a high altitude setting, but to my knowledge, I haven't seen recent data with that. And I think we would want that data more recent because of the introduction of the pneumococcal conjugate vaccine, Hib, and to kind of better understand the current respiratory pathogen contribution to the disease.
Thank you. Just waiting for questions to come in. I see there's a question from Sofia Constantinopoulou. And the question is, any strategy to help medical colleagues how to prevent and manage pneumonia in children in war-zone areas such as Gaza and Sudan currently?
Thanks for the question. Yeah, an increasing proportion of childhood pneumonia deaths are concentrated in fragile settings, whether that's affected by conflict, climate, natural disasters. So it's always in these areas where the health system itself, the capacity to diagnose and treat has broken down, it's always better to prevent. So vaccination strategies can come into their own in these challenging settings. There's some very interesting studies going on at the moment on what's called fractional doses of pneumococcal conjugate vaccine. The Gates Foundation and several other donors are funding these. There's one in Niger. There's several, I think, in South Sudan, and we have some data on this. I'll put it into the chat in a minute. So this is a much more affordable way. It's done campaign style of protecting the children. Also, just giving them these kids don't typically get PCV. They're very under-vaccinated. There's a lot of zero-dose children. So I would say if you're really interested and focused on helping children in these settings, get involved in some of the pneumonia vaccination strategies. PCV, Hib, measles is very important. It can cause pneumonia because there's a lot of research going on in that area, and I'll drop it into the chat now so you can check it out.
Well, thank you. Ali, just a follow-up question to your presentation regarding availability of RSV vaccine. And knowing that RSV is such an important pathogen around the world, is it available, accessible now? And how do you foresee it being included in EPI programs, and when? Yes.
So the good news, there's two preventative tools for RSV. There's the maternal vaccine given there's a window of time during, I think it's the third trimester when pregnant women are recommended to have one dose of RSV. And then there's the monoclonal antibodies, another option where the baby is given that one injection just after birth. And you families, hopefully in an ideal world, would have a choice, what they preferred. So health systems would offer both. We are just getting that together in the US and Europe. It's nowhere near a fait accompli in low resource settings. But the good news is there's a huge agenda to accelerate introduction of both tools in low resource settings. So today's World Pneumonia Day, if you go and take a look at the conversation on X or some of the other social media platforms, you'll see a huge amount of RSV material. There's a new chat bot. It's called the RSV chat bot that's just been launched by ResVinet, a foundation that's dedicated to getting these tools out. Anyone can download this on their WhatsApp. It's going to answers all your questions. It's a beautiful AI-enabled tool. The Gates Foundation, I must say, the maternal vaccine for the Gates Foundation is a top priority. So expect to see them very, very much involved, and Gavi hopefully very, very much involved in rolling out the maternal vaccine. The WHO has just recommended both tools, the RSV maternal and monoclonal. So that hurdle has been crossed. So in the next 2 to 5 years are crucial for these tools. So expect to see a huge amount of activity, and we hope a lot of the clinicians will get involved in that because the burden concentrates among children under 6 months of age. That's a really difficult. Our current tools really struggle to get at children in that age group. So there's huge life-saving potential here for RSV. I'll also drop those in the chat. The RSV chatbot is awesome. You should all play around with it.
Thank you. And I think we have time for one last question. And this one is for you, Rebecca. So prevention of malnutrition came up as one of the key strategies. Just interested on kind of the key take on nutritional supplements or nutritional supplementation or rehabilitation for children with pneumonia who do not have severe malnutrition.
Thank you for that question. I think research has been done looking at children with pneumonia and some supplementation like zinc and vitamin A. But I think for me, the most important part is not necessarily the supplementation, but really looking at preventing the malnutrition by giving children the right foods to eat right from the start. But I know that there are some characteristics that we look out to for some children, and then those ones would need supplementation. But I think the focus should be really preventing undernutrition by giving the right foods. That's what I would recommend, other than waiting for supplementation. Thank you.
Well, thank you. Thank you first to all the panelists for these very inspiring talks and also sharing such important information. And thank you to all the attendees for being here with us on World Pneumonia Day. So thank you so much.
Thanks, everyone.
Thank you.
Thank you. Bye.
Bye.